Good day. I'm Anthony Henbridge. I'm an abdominal radiologist at the Joint Department of Medical Imaging, University of Toronto. And today we're going to discuss ultrasound of adnexal masses in two parts. Our learning objectives will describe a sonographic technique for optimal detection and characterization of adnexal disease. We'll list the common adnexal masses and describe distinguishing features, and we'll identify adnexal masses as high risk or low risk for malignancy. Now, endovaginal ultrasound has a very high negative predictive value for malignancy when evaluating adnexal masses. So it has emerged as the most practical modality for the initial assessment of these patients. Following the ultrasound examination, it should be possible in most cases to issue recommendations such as to dismiss or follow a benign mass, or if there is a high risk of malignancy, perhaps surgery can be considered directly from the ultrasound examination. For the more indeterminate masses, MRI may be recommended because it may be more specific at characterizing these masses, and it's preferable to CT because it does not involve ionizing radiation. So how do we set about stratifying adnexal masses as having a high or low risk for malignancy? Well, it's a combination of things, including clinical history, the location or organ of origin of the mass, a careful morphologic analysis, and prudent use of color Doppler. Some of the advantages of endovaginal ultrasound over transabdominal ultrasound is that it offers improved localization of the mass to the ovary, the fallopian tube, or uterus, improved characterization of the mass as cystic or solid, and if cystic, a very detailed assessment of the cyst content, but also very importantly of the cyst wall, looking in particular for mural nodules, particularly vascular mural nodules. Endovaginal ultrasound also offers a dynamic assessment, which I will demonstrate here. What I mean by a dynamic assessment, this is a young woman who's pregnant. She has a positive beta HCG, and there's concern regarding an ectopic pregnancy. Here we see the ovary, and adjacent to the ovary, this thick-walled cystic structure. With a static image, even in experienced hands, it would be difficult to say whether this thick-walled cystic structure is an exophytic corpus luteal cyst, or if it is in fact an ectopic pregnancy adjacent to the ovary. So using this dynamic assessment, we can see that this thick-walled cystic mass moves independently of the ovary and is therefore likely not arising from the ovary and is much more likely to be an ectopic pregnancy rather than a corpus luteal cyst. On the contrary, in this case, we see the uterus here on your left, and adjacent to it, a solid hypoechoic adnexal mass. Is this a concerning solid ovarian mass, or is it a subserosal fibroid exophytic from the uterus? And we can see here with this dynamic assessment that it's impossible to separate this mass from the uterus, and it's therefore likely arising from the uterus rather than from the ovary. You would, of course, look for and hopefully demonstrate a normal ovary on each side, but this adds additional useful information. A variant on this technique is keeping the endovaginal probe static and then palpating this large echogenic adnexal mass with the free suprapubic scan. And when doing this, we can see that this mass moves independent of the uterus and offering evidence that it's arising from a structure other than the uterus. And in this case, this was a large dermoid cyst or mature teratoma arising from the ovary. So this is a very helpful technique and will add additional useful information. What about the use of Doppler in these cases? So one important use is to help confirm or refute flow in a solid mural nodule. Let me demonstrate. This is a young woman. This is an ovarian cystic mass with a large solid component. What is this mass? Is it concerning? When we add Doppler, it adds confidence that this solid component is not vascular. Doppler, of course, is not highly sensitive for vascularity, so if there's just a small amount of flow, it may not be visible with Doppler. But this appearance, nonetheless, is very characteristic of a hemorrhagic cyst with retractile blood clot. So this is a more mature hemorrhagic cyst where the blood clot is organized and is retracting away from the cyst wall. On the contrary, here's a similar sized ovarian cyst with a very small mural nodule. And when we add Doppler here, and notice not just color Doppler, it's important to do a spectral tracing, we can see that this small nodule has arterial blood flow. And this complex cystic mass with a vascular mural nodule is therefore highly concerning for a low malignant potential tumor of the ovary or ovarian cancer. And endovaginal ultrasound is very sensitive for demonstrating these small mural nodules. So another good use of Doppler is in the presence or concern regarding ovarian torsion, where absent or diminished blood flow in the ovary of concern is helpful to add confidence to the diagnosis. Here's an example where this patient had pain on the side of the enlarged ovary on your left. We'll notice that the scale is the same for the enlarged ovary and the normal ovary. And when we add color Doppler using the same color scale, flow was easily visible in the normal ovary, but was not visible in on the enlarged concerning side. So this absence of flow adds confidence. The contrary is not true. If there is flow in an enlarged ovary and it's a sudden onset of pain, it does not necessarily mean that torsion is not present. So you need to be aware of that. You can have an ovarian or adnexal torsion with preservation of some flow in the involved ovary. Another good use of Doppler is in the postmenopausal patient if there is increased blood flow in the ovary. So usually in postmenopausal patients, the ovaries will be small and relatively avascular, but in this particular postmenopausal patient, there was quite a lot of flow in this mildly enlarged heterogeneous ovary, and this ovary was subsequently shown to contain ovarian cancer. And finally, another good use of Doppler is in the case of subserosal fibroids, where it may be possible to document a feeding vessel from the uterus. So in the slide on your left, this is the uterus. It's a transverse or transverse oblique image. And here in the adnexa is a solid adnexal mass. Again, the question arises, is that an ovarian mass or is that mass arising from the uterus? And when we add color Doppler, we can see this feeding vessel coming from the uterus supplying the right ovary, or the right solid adnexal mass. The ovary was demonstrated separate from this mass. Where Doppler is not useful is analysis of the spectral tracing. Many studies have been performed over the years with the hypothesis that there may be reduced pulsatility and resistive indices in malignant masses relative to benign masses. This in particular has been studied in complex cystic masses to try and determine if they're cystadenomas or cystadenocarcinomas. And studies in general have shown that population-wise there is a tendency towards reduced pulsatility and resistive indices in malignant masses, but there's quite a bit of overlap with benign masses, and in individual patients it's probably not helpful and not worth the additional time that this assessment involves. Now, I'm going to share with you a couple of slides on key points when you're faced with a woman with an adnexal mass. And these points will help you in stratifying masses as lightly benign, indeterminate, or lightly malignant. The first set of key points relate to the clinical history. And the most important thing to establish is the patient pre- or postmenopausal. It's also important to know if the patient is pregnant, is there an acute or chronic presentation, or is the mass an incidental finding and the patient is asymptomatic? Is there a history of infertility or dysmenorrhea, which might suggest diagnosis such as pelvic inflammatory disease or endometriosis? Is there a family history of ovarian cancer? Is the CA-125 elevated, a blood marker for ovarian cancer, although it's not highly specific? Is there a history of previous surgery, or is there a history of past gynecologic cancer in the patient you're scanning? For example, a previous right oophorectomy for a low malignant potential tumor. One might interpret a complex cyst in the left ovary in that particular patient a little different than in a patient from the general population. The second set of key points relate to the sonomorphology. And the most important point here is deciding or establishing if the mass is arising from the ovary or is it arising outside the ovary. The size of the mass is also of some value. Is it cystic or solid? And if cystic, what's the morphology of that cyst? Looking particularly for mural nodularity and particularly vascular mural nodules. It's also important to look for ascites, and if there is free fluid in the abdomen and pelvis, to characterize that ascites as clear or particulate. The reason these key points are so important is that there are a number of useful facts relating to ovarian masses. And the first useful fact is that if you have an intra-ovarian mass in a premenopausal patient, 95% of these masses are physiologic, even in patients on the birth control pill, and 90% of these masses will resolve by 6 weeks. So if on the majority of masses, you repeat an ultrasound examination in 6 to 8 weeks, usually immediately following a period, then the majority of these masses will have resolved. And of those that haven't resolved, a smaller number will evolve. The sonomorphology will change, particularly in the case of hemorrhagic cysts. Another important fact is that if you have an intra-ovarian mass in a postmenopausal patient, in general, it's cause for concern, the exception being a completely simple cyst. There's also one solid mass that maybe we can follow, but I will discuss that later. Solid ovarian masses, whether pre- or postmenopausal, you should regard as being malignant. But the exception I alluded to is the fibroma or fibrothecoma. They can have a very specific sonomorphology, are benign, and can probably be followed, particularly in older patients who may have other comorbidities. But the twister on this rule is that the most common solid adnexal mass is not an ovarian mass. It in fact is a subserosal fibroid arising from the uterus and extending into the adnexa. But before you're comfortable calling a mass a subserosal fibroid, ideally you should document a normal ovary on each side. Other useful facts: a simple intraovarian cyst is invariably benign, even if the patient is postmenopausal, whereas an extraovarian cystic mass is invariably benign, even if it's complex. Some other useful facts is that there are many adnexal or ovarian masses that have a specific appearance, and this is true of almost all fibromas or fibrothecomas, most dermoid cysts, some ectopic pregnancies, many endometriomas, and many hemorrhagic cysts. Less useful facts, but that may flavor your interpretation of an adnexal mass, is a family history of ovarian cancer, because then the patient that you're dealing with has an increased likelihood of having ovarian cancer. If the patient you're scanning has a history of previous ovarian cancer, or if the CA-125 is elevated. So let's start then at the lower end of the spectrum, the simple ovarian cyst. Remember that no cyst is simple unless it's simple with the endovaginal probe. And what we're looking at to define a simple cyst is a thin, smooth wall, no septations, no internal echoes, and through transmission. So here's an example of a simple cyst. Note it's simple with the endovaginal probe. It's completely anechoic. It's demonstrating through transmission. It's growing in the ovary, so it's displacing some ovarian tissue to the side. And we know this is ovarian tissue because we see small follicles within this ovary. On careful evaluation, there's no wall irregularity, no mural nodules, and no internal septation. So this is a small, simple ovarian cyst. And I would like to refer you all to this excellent article, Recommendations from the Society of Radiologists in Ultrasound, published in Radiology in September 2010, which has recommendations for management of simple cysts and indeed some complex cysts, but we'll focus here on simple cysts in asymptomatic women. And a summary of some of the recommendations I will highlight here. So in women of reproductive age who are asymptomatic, and this refers to simple cysts, if there are less than or equal to 3 centimeters in greatest dimension, it should be considered a normal finding and a recommendation for no follow-up. If the greatest dimension is greater than 3 centimeters and less than or equal to 5 centimeters, the cyst should be described in the report, but again, no follow-up recommended. If the cyst is greater than 5 centimeters or less than or equal to 7 centimeters, describe the cyst and recommend a yearly follow-up. And if greater than 7 centimeters, the society suggests further imaging with MRI, because once a cyst reaches that size, it may be very difficult to interrogate the entire cyst wall with endovaginal ultrasound, so small wall irregularity or mural nodularity could be overlooked. Remember, these are simple cysts in the asymptomatic woman. On the other hand, in the postmenopausal asymptomatic woman, simple cysts less than or equal to 1 centimeter are considered clinically inconsequential, no follow-up. If they're greater than 1 centimeter and less than or equal to 7 centimeters, you should describe the cyst with yearly follow-up, at least initially. And there was some discussion at the society whether that lower measurement of 1 centimeter should be increased to 3 centimeters. So there is some flexibility there if you're following the guidelines. And cysts greater than 7 centimeters, again, are so large that they probably should be further imaged with MRI in an effort to better characterize them, or indeed surgical evaluation could be considered. Another group of benign cysts are the hemorrhagic cysts, particularly in the women of reproductive age. And these are cysts that often have fine internal stranding, retractile blood clots, low-level internal echoes, and if you elect to follow these cysts because you have some level of concern, they should show resolution. In fact, the majority will show resolution, often within 6 to 8 weeks, while others may show evolution, which stresses the importance of comparing your findings with the previous images. Here's a nice example of a hemorrhagic cyst, very typical, lace-like internal stranding. This is a cyst in the right ovary, and this cyst was followed, and 8 weeks later, immediately following a period, that cyst has resolved and the ovary appears completely normal. Another appearance that I've already shown you is the retractile blood clot. This is an example of organized blood clot within an ovarian cyst, and as it organizes, it retracts away from the cyst wall. And on ultrasound, it has a very typical sonomorphology where we see the solid component retracting away from the cyst wall, and again, with the use of Doppler, adding support that there's no flow in that solid component, and you can be very comfortable with the diagnosis in a premenopausal patient. And as the blood clot retracts more, it can become a little more irregular, but again, a fairly typical appearance. And here's an example of evolution in the sonomorphology of a hemorrhagic cyst. The image on your left, the lace-like internal stranding, where 6 weeks later the stranding has broken down and we're left with a cyst of similar size with low-level internal echoes. So that brings me to the end of part 1. I'd like to emphasize the key points. On clinical history, is the patient premenopausal or postmenopausal? On sonomorphology, is the adnexal mass intraovarian, that is arising from the ovary, or is it extraovarian? And the importance of those key points is that in a premenopausal patient, if you find an ovarian mass, the vast majority will be physiologic masses, most often functional cysts, sometimes functional hemorrhagic cysts, and the majority of those cysts will resolve with follow-up. Thank you very much.